guys hear me okay? All right. I usually don't get told I'm too quiet, so that usually works out okay in a room like this. So I'm very conflicted, and we'll talk a little bit about BTKs, which is not the serial murderer that was in Kansas, but we'll talk about Bruton tyrosine kinases. So these are drugs that basically inhibit this drug, and it's kind of the big next drug class that we're seeing a lot of excitement about. So this is a little bit of a taster for something that's going to probably not be with us for at least another year, probably closer to 2 years. But it gives you sort of like a lot of the questions that we tend to get are like, what's coming up? And there's a lot of information that's going to be coming up about these drug classes. So this is a little bit of a taste for this. And there's at least 8 of these that are probably being considered for MS, and that's just the ones I know of. So there's probably a lot more than that that are being considered. So we'll talk a little bit about what the differences might be and this and that. And then we'll talk about why there might be so many of them. I think it's mostly the simple answer to that is just because there's a lot of interest in this drug class. And so everybody is looking at trying to kind of get in on it. And so some of this stuff will get a little bit complicated, kind of very sciencey. I'll try to kind of break it down as much, but I think the main point about this is a new drug class. The reality is we don't know much about them yet. So there's going to be a lot more to come. So that's kind of the summary statement all at the beginning. So don't worry if you miss stuff, because I guess we'll probably be talking about these drugs a lot in the next 2 to 4 to 5 years. So that's kind of what it looks like down here. We can see that there's a lot of different domains, and we'll talk a little bit about what this means. And basically, most of these drugs are kind of going after this part, which is the kinase part, which is the active part of the drug. And we'll talk a little bit about what that means. So you might say, like, why do we need more drugs when our landmark looks like this? And you might not be wrong. I think part of the issue is that when we look at progressive disease, this is basically what it looks like. We don't have a lot. We might be able to add on rituximab, not FDA approved, but we're very limited in what we have for progressive disease. And so there's a lot of questions already that I was kind of skimming through that basically ask what is coming up for progressive disease. And I think it's excitement about this drug class. This is kind of one of the things that's coming up for progressive disease. The other part you'll start to notice down here, all these are BTK inhibitors. So the big chunk of stuff that's coming up is at least this kind of group of drugs. And I will often call them by nicknames or short names because you can see that a lot of them end up by utinib, and that just gets really repetitive to say. So we might call them like Evo, Feni, Toli, Remi, you know, that kind of stuff. So to try and keep it a little bit of less of an alphabet soup, we'll do a little bit of that. There's a lot of excitement about these drugs. I showed you the ones that were being looked at in MS, but there's a lot of them being looked at just for other autoimmune diseases. So you could see here, rheumatoid arthritis, lupus, MS, Sjogren's, not sure, ITP, graft versus host disease, asthma, a lot of clinical trials, even more drugs being looked at. So it just kind of depends on, you know, sort of what the company that has the drug is interested in, you know, what they're kind of looking at it. But the point is that there's a lot of studies that are being looked at, and this is number of studies being looked at in these types of diseases. So there's a lot of different things kind of happening, and this slide's already a couple years old, so you can only imagine this list has gotten much longer and bigger and things. This is not necessarily a new drug class. Ibrutinib already was approved in 2013. Now, it was approved in cancer, so we don't have a lot of experience with it in MS. And ibrutinib, we tend to think about it as being a dirty BTK inhibitor. I'll explain what that means in a little bit. But the idea with the MS is to try and make them a little bit cleaner, more specific to the Bruton's tyrosine kinases, because this is a big drug class. And you can see that they started getting developed, okay, maybe not in 52, but really starting to kind of get developed in 2011. The first phase 1 trial was 2009. So we have a little bit of history with this drug classes. Again, different patient population, and maybe what they tolerate for some of these other drugs is a little bit bigger than maybe what we want to tolerate in MS, where sometimes we have to treat with these drugs much longer than you might treat a cancer patient, for example. But already in this time, we can see that we have ibrutinib in 2013, Aurora, you get the point. There's another drug that is already approved in cancer, and this one's actually approved in China, so not in the US. This one was actually looked at in MS. And we just heard last month that actually Biogen, who had this drug, passed it back on to the Chinese company because they had some liver issues with it in the US. Here's a couple of more that got approved in the US. And again, so far, so this is a little bit more about cancer stuff. But just to kind of say, hey, we have some experience with these drug classes. So what's a tyrosine kinase? There's hundreds of these things. Basically, when you talk about sort of cells and how they get stuff done, another cell might put out a chemical. What sees that chemical are receptors. And these receptors work by, they have to form dimers that basically pair up. Sometimes it's two of the same molecule. Sometimes it's a different one, two different molecules that come together. That sort of activates them. This becomes active. And then they're able to kind of send messages and activate other proteins inside of a cell that make that cell active and kind of respond to it, right? So you think about it as like, hey, there's a cell up here and it's trying to communicate with this cell. It sends some messages. It kind of picks the right receptors, and then you can kind of send different signals for that cell to kind of activate it, okay? BTK, or Bruton's tyrosine kinase, is one of these proteins inside of here that sends messages that tell the cell what to do inside that cell. There's several different types of messages where BTKs are involved. So B cell receptor, we like B cells. We hear a lot about B cells. We usually take out B cells. So if we inhibit this, you can see that we might be able to inhibit a lot of different things inside of those B cells. But additionally, you have other types of receptors that might give you some extra functionality. You might be able to inhibit other types of cells beyond just B cells. And we'll talk about some of those cells where these molecules might be important. The other thing is that these are small molecules, so that a lot of times they're able to make it into the brain and be able to then affect this to be able to inhibit signaling that usually activates cells. All right, so what kind of functions are BTKs then involved in? Hit the right button, there we go. So we talk about, we know already the function in B cells. If we can, these are cells that we usually try and take out with drugs like rituximab and Ocrevus and ofatumumab and now olutasidenib. But BTKs might be involved in pathways that we think are also maybe involved in MS, right? So we talk a lot about remyelination. So these drugs might help with kind of inhibiting some inflammation and allowing this remyelination to happen. Microglia is a type of cell that's part of the immune system inside the brain. And so these are cells that we usually don't think we affect too much with antibodies that have a hard time making it inside the brain. So the moral of the story for this is small molecule can make it into the brain and do stuff that other drugs can't do. They also might help with sort of this active cells coming in from the blood and making it inside the brain, crossing the blood-brain barrier, crossing those blood vessels into the brain, where they can lead to that inflammation. And again, here you see another microglia, so it can help with the transport and might affect some of these other cells that we know are involved sometimes in MS, whether they're affected early or later on in MS. Those are the kind of things that we don't know very well at this point. But moral of the story, we can affect a lot of different things that we think is involved in MS by affecting this protein. All right, I mentioned that there's hundreds of different tyrosine kinases. So if you put a small drug, as opposed to antibodies that are very specific, part of the problem is that these drugs might affect other types of tyrosine kinases. And when I was talking about ibrutinib, that first one that got approved being a dirty drug, part of that has to do because it hits not just Bruton tyrosine kinase, but TEC, ITK, BMX, TEEK. Anyway, you get the point. But here's ibrutinib, and you can see the smaller the number, the less of that drug it takes to affect that protein. So low numbers means it affects Bruton tyrosine kinase, TEC, all these other ones. And then we have very sort of specific ones, phenybrutinib, for example, Phenny, where it affects BTK, but then it takes a lot to affect other ones. It might affect BMX as well, some. But you can see that there's at least almost a tenfold difference. You need 10 times as much drug here to affect this tyrosine kinase than this one. So this idea of trying to make them cleaner is what we're trying to kind of get at with MS. And the idea is, like, if this one, for example, leads to bleeding side effects, if you don't affect that one, you might not then have bleeding events associated with your drug. So we tend to like clean drugs for that matter because it just becomes more specific and you don't affect as much stuff. So big difference between these drugs, and that's why in MS we're looking at trying to get drugs that are a little bit cleaner than we might with other drugs. And again, not that all of these are being looked at in MS, but just to kind of tell you there's a lot of these and that different drugs affect different combinations of these. So this might be a good thing or a bad thing. I mentioned it might be a good thing because you might be able to get rid of rash and diarrhea if you don't affect EGFR receptor. You might get rid of heart issues such as atrial fibrillation if you don't affect CSK. It might be maybe a bad thing if you also are hitting TEC, for example, and that also helps to limit the B cells. So if you can affect several of these proteins, you might be able to affect other types of cells. You might be able to have an effect on T cells if you affect the RLK/TXK protein. And so how much and how good, again, the point of this is each drug's going to be slightly different. These aren't a lot of very much like Me Too type drugs. And we're going to have to just see what a lot of these drugs look like. And so you affect a lot of different tyrosine kinases for good or for bad for some of these things. All right, so these are primarily the ones that are being looked at in MS. And mostly kind of from the ones closest to coming out to the ones that are a little bit farther away from coming out. And I've listed a few, and actually the one from BMS might be a different one than this. I know they're looking at one, I just didn't know which one, so I picked one that looked like it might be the one being affected in MS. This is one that they're looking at in other autoimmune conditions. TG has one that they're kind of looking at developing. One of these has already kind of dropped out, as I mentioned, at least in the US, with the orelabrutinib one because of liver issues. This one got stopped in the US. They've turned it back over to China, but it's already approved in China, for example. So we'll talk a little bit about these. Some of the differences is you'll notice that most of the time they're twice-a-day drugs. Tolebrutinib is the one exception. It is a once-a-day drug. These drugs, whether this matters or not, again, we'll have to kind of see. Sometimes when they bind to that tyrosine kinase, it can pop back off and the tyrosine kinase can be active. Or sometimes when it binds that tyrosine kinase, it doesn't pop off and it's inhibited permanently. So it might have a little bit of a longer effect for good or for bad or things like this. But one of the differences and one of the maybe advantages of BTKs over, for example, taking out those B cells completely with antibodies is that it takes months for those B cells to come back, right? You do the infusion once every 6 months, you do the shot once a month, and then it might take 4 months for those B cells to come back. Once you take out Bruton tyrosine kinase, it might take 2 weeks for those tyrosine kinases to come back. So you're not taking out the cell, you're just taking out that pathway. So if you run into issues like infections or things like this, it allows for things to come back much faster than that depletion might. I wouldn't worry too much about this. This is just at what concentration do you inhibit them? So sometimes you might see that, you might need more of the drug or less of the drug. And that has to do with just how potent the drug is. And that's, again, adjusted by the dose for the most part. One of the things I'm starting to kind of notice here bold and underlines and emphasize is we're starting to kind of see a few cases of liver issues with this drug class. Okay, and so not to bring up a Budweiser commercial, but there's something called DILI. So dilly dilly, you know, from the Budweiser commercials, has to do with drug-induced liver injury, and that has stopped the development or has put holds on the recruitment for patients into some of these trials. And so that's something that we're going to have to monitor. So far, for the most part, it's been reversible. You stop the drug and the liver gets better. There has been one death with tolebrutinib. And so this one is fully enrolled, but it's no longer recruiting in the, you know, it got put on hold from a recruitment perspective. So the trial finished off recruitment in Europe, and mostly Eastern Europe, because of those cases. The FDA put a kibosh on it. Otherwise, it's infections and things like this, as you might expect, and you know all the stuff that tends to happen in trials, like headaches. So whether that's drug specific or not, we don't know yet, but we'll need to kind of see what that comes out to be a little bit more. This is kind of where we're at timing wise. So these actually skipped phase 2 trials. These had phase 2 trials, but I'm going to talk a little bit more about just the phase 3 trials. And we're kind of looking at approval, and these are my guesses, so I might be way off, but just I was taking a stab at it. And I'm thinking like early 2025, late 2025 for tolebrutinib, 25, 26, 26, and some of these are, you know, mostly still at the phase 2 trial, so coming out later. So we got a little bit of time to kind of figure out some of these things, and we'll have to see what the trials are looking like. Let's see, anything else I wanted to say from this? I think we can go on and talk about some of these trials. Oh, the one thing I would mention then, so there's excitement for this for progression, mostly because the microglia, we tend to think about it as being part of that progression pathway, partly because we think that maybe it's the B cells and T cells inside the brain that are important, so these drugs make it into the brain. And so these are the drugs that are actually being looked at in progressive MS. And you can see that tolebrutinib was looking at secondary progressive and primary progressive. Fentrepid is actually being looked at in primary progressive MS. And for us, very excitingly, it was actually it's being compared to ocrelizumab. So it's a, you know, they're going up against the one drug that's approved for progressive disease. So for us, that made it really kind of exciting. We have almost 20 patients in that clinical trial, so you can tell that we're excited, and I think patients that we told about the study are very excited about that study. We're pretty much involved with all of these trials. This one we don't have at our site. I'm involved with looking at relapses and adjudicating them to see if we think that they're real relapses or not. So let's talk about some of these phase 3 trials just to kind of give you a little bit of idea. So we don't have data from phase 3 trials. So we have data from phase 2 trials for 2 of these drugs. One is evobrutinib. This is the one that's a little bit farther ahead. This was a little bit more of our standard phase 2 trial where they looked at multiple different doses, had a placebo. The placebo got switched over after 24 weeks. And we can see that the number of contrast-enhanced lesions or active lesions came down nicely, that the number of new T2 lesions came down nicely. The moral of the story is a little bit here. The numbers from a relapsing perspective were okay. They look like most of our oral drugs. They didn't look necessarily like our infusion drugs. So we'll have to see, you know, what that actually looks like in the big phase 3 trials. How they looked at it was a little bit different. They didn't look at number of lesions. They looked at lesion rate ratios, and it was a very stats type heavy process to look at this. So does the drug look better than this? Does it look worse than this? Again, I think we just need to wait for the phase 3 trials so that we have a better sense to see, like, are these going to be really good drugs or kind of middle of the road drugs or things like that. They've also changed their dosing a little bit. So when they started their phase 3 trial, they went with the 75 once a day, and then they switched it to the 75 twice a day. And so there's a little bit of changes that happened in this trial as we learned about these drugs. So this is one of those things that we use these trials to learn about drugs and how they should be used, once a day dosing, twice a day dosing, what dose, and things like that. The side effects, curiously, did not have any big increase in liver enzymes. These are the columns for the liver enzymes. This is all the side effects that we're seeing. And it looks pretty much the same throughout whatever dose you look at. So in the phase 2 trial, there was no liver issues. 2 or 3 days ago, we heard that even though the trial is recruited, it got put on hold, so they can't get any more patients that they tried in the US because there were 2 cases of DILIs, of that drug-induced liver injury stuff. So again, one of these things that now we're starting to see it in a little bit more of these drugs, and we have to see it. Those 2 patients didn't have any symptoms. It was just as they were checking those labs, they saw that the liver enzyme bumped up a little bit. The other study for phase 2 was the tolebrutinib study. And this was a very stats-heavy study. They were trying to reduce how little placebo patients would have to take. And so patients only had 4 weeks of placebo before they got drug, and they got the placebo at the beginning or at the end. So it was a lot of sort of stats adjustment to kind of see. And this is the drug that also is on hold. This one had, I think they're up to about 6 cases of that DILI stuff. And again, there was 1 death. 1 patient required a liver transplant and then subsequently died from that. So seeing kind of what this looks like again, we'll have to see if this makes it or doesn't make it. This finished recruiting in Europe, and Europe was a little bit more open to allowing recruitment into this study. But the numbers look really, really good. So from a relapsing perspective, we can see reductions of 85% and almost 90% as far as lesions go. So this looks like really high efficacy type drugs. Again, no liver enzyme seen in the phase 2. That was all seen in the phase 3 type stuff. And so just again, this is a very exciting drug class. There's a lot of trials for which we have absolutely no data in progressive disease. So we're going to need to get that data and see what they look like. We're going to have to monitor these liver side effects. I think that's the main side effect that we're really seeing. The original drugs had some bleeding effects. You couldn't take like aspirin with them. That's been removed by being drugged with the cleaner drugs. So now we can start, it's become much less of a concern. So I think we've been able to eliminate some of that stuff. We'll be able to eliminate the liver stuff, or is that specific to the Bruton tyrosine kinase? We don't know. And then when we have a lot of drugs, from a relapsing perspective, how do they fit? How do we mix and match them with the CD20s? And then from a progressive perspective, we'll just have to see what the data looks like. They might be really good, or they may fall flat. So with that, we'll do questions later, and we have a break now, right? Break? Perfect.